So now we are going to continue our live surgeries, and the third case is in. This is a an old woman, and she is how many? 63 years old, and she suffered from cephalalgia on temporal left side, um, retroorbital also a location of cephalalgia, and it's the main reason to do solicitation with its family practitioner. So he prescribed CT scan and he diagnoses tumor in the posterior part of the olfactory cleft and the sphenoid on the left side. So next, she gone to an ENT surgeon, okay, and um, in fact the endoscopic aspect is like a sphenoconal polyp, but it's not sure. It may be inverted papilloma. I don't know. Okay, and here you can see the CT scan, and on the axial plane, you will see that the pathological process concerns the left sphenoid sinus, and the posterior ethmoid, and the posterior part of the olfactory cleft. Okay, good. Without any bone disease, except the enlargement of the natural osteum of the sphenoid sinus. Okay, and on the coronal view, okay, you can see that the posterior part of the olfactory cleft is fulfilled by the polyp, not the anterior and middle ethmoid, not the maxillary sinus, and fulfilled completely the posterior cavities and blocked the coronal arch, explaining why this woman suffered also from moderate nasal obstruction, because the obstruction is not complete. Okay, so the job is to remove it completely, whatever the histology, to search the pedicle attachment, and I think it's maybe in the sphenoid cavity. So to enlarge completely the sphenoidectomy, to give a good access uh, at the inner part of the sphenoid sinus. Okay, and after we wait the histological analysis, the result of the anatological analysis. Okay, so we are going to start now. Previous to start the surgery, we put in place, my assistant put in place printed curtain top in oxybitazoline 10 minutes before. like that. Okay. So the light is switch on. Okay. Yes. 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 So on the left side, okay, this is the endoscopy. As you can see, you see here the middle turbinate, and with the spatula, please. Uh, okay, behind you have here this polyp, and with secretion. Okay. Oh, I think it's probably a sphenocoanal polyp due to the aspect. Okay. It is surrounded by a pew, explaining why probably this woman suffered from fibromyalgia. Okay, but we haven't characteristic of completely blocked the cavum, not completely, but almost. Okay, you haven't the characteristic of inverted papilloma. Are you agree with me, Chloe?
Yes.
Yes. Okay. So we are going to remove with the fine fenestrated straight forceps. Straight forceps. Yes. Merci. Straight is a straight. Okay. Like that. Okay. Look. Okay. Like ça, hein. It remains this part of polyp. Yes. Good. With how there is fungus ball. So it's maybe, yes, sentinel polyp of chronic fungus ball. Okay. Uh, sorry, like that. Okay. So, je prends. Il y aura de la mycologie. So, we do also some mycological sample. Okay, so now the coronal arch is free. Okay, the problem of nasal obstruction is treated, but not the disease. So, due to the volume of the middle turbinate, I'm going to cut it because it's impossible to reach in good condition the anterior surface of the sphenoid sinus. So I cut posteriorly compared to the previous cases. Okay. And I remove the superior part, only the superior, the inferior part, of course. Okay. Oh, another secretion. Okay. Okay. Oh, it maybe uh, chronic venous sinusitis with xenophil due to the aspect of mucus. Okay, scissors, please. Okay. Pas encore. Yes. I'm going now to remove the middle turbinate, like that. This is the middle turbinate. Okay. As you can see, the bleeding is very, very small. And now it's possible to reach here the surface. Here you have fire. The tail of the middle turbinate. Okay. So I do the coagulation. So yes. Yes. Okay. Okay. So now, 45-degree fenestrated forceps. And I'm going to expose the posterior part of the olfactory cleft. Okay. But it looks like chronic venous sinusitis with the second type of non-invasive. Yes. Ecological disease. Okay. Okay, straight suction tube, because I'm going to search. I'm just searching the natural osteum, and I remind you that this osteum is enlarged by the disease. So I think it's above and behind the tail of the superior turbinate, the ear. Okay? So, Kerrison forceps. Vers le bas. Okay. Yes. This forceps cuts the bone. Okay. It's the reason why I twist my forceps, okay, along its longitudinal axis, avoiding to catch and to crush the different wall of the sphenoid sinus. Now, please give me the other Kerrison. And next, I'm going to do some wash. Yes, but in the good direction. Yes, like that. Oh, I think it's allergic fungus sinusitis. Yes. lavage. Not a sphenocoanal polyp, and not an inverted papilloma. Look, this very specific mucus, the mucin, the allergic mucin, okay? C'est assez long, ça. Ok. Pas une lutte.
Non, c'est pas une lutte.
Non, c'est bon. J'aurais tout mis le temps que t'arrives. Ok. Vigon. Look, this particular mucin. So we continue to wash, to do the extirpation of this very thick mucus. Ouais. Ok. Allez. Lavage. So the job is to wash behind this material. Look. Look at this. Berk. Okay. Forceps. Yes. Okay. Irrigation. Yes. Look. Another piece. Forceps, please. That. And like that. So now the sphenoid is a little bit okay. 45 pins. So histology to control if it's an invasive or not. There is some forceps vers le haut. Comment tu dis? Ah, non, pas du tout, non. Méchant, toi. C'est méchant. Ah, bah, c'est ça, okay. So don't forget that it remains, look, the posterior ethmoid, okay, which is fulfilled by the secretion. So I'm going to open it. So 45 degrees per sec. And of course, it remains some inflammation inside. Ça, tu mets la postérieure. Okay. Yes. Yes, it remains some mucin inside. Okay. So 45. This is the superior part of the entire wall of the ear sphenoid. So I remove it completely because we need to flatten this area. And don't forget that after this patient needs some follow-up. So it's your job to organize the space to do easy follow-up with the endoscope. Okay, so I think it's better to remove, yes, Rouvier, the uncinate process to open completely the ethmoid, in fact. Okay, so very easy here. Okay, with the bubble of nitric oxide. Okay, a straight scissors to cut. Okay, along the back of the middle turbinate. Next, straight forceps to remove the horizontal part of the uncinate process. Okay. Maxillary sinus is normal. Okay. And I want to control the anterior ethmoid. 45. Okay. So I complete. Oh, it's not normal. Anterior ethmoid. Yes. It's better to control. Yes. All of cavities in this disease because the surgical job is to flatten the different area. Okay. And to empty all of cavities to avoid any recurrence. If it's a good diagnosis of um, allergic fungus sinusitis, you need to use corticosteroid after surgical treatment, okay, to avoid any recurrence, okay. We used a short cure of general corticosteroid therapy during 10 days, followed by 1 month of local treatment, avoiding a recurrence of this specific immunologic response. Okay, tiens, vas-y. Okay, it's a good case with a good visibility. Okay. So I do the anterior ethmoidectomy to have some margin and to control the contents of this space, but in fact it's not, and to organize the follow-up in fact, because the follow-up is not with image but with endoscopy. Okay, and okay. Ah, oh, okay, so we control the maxillary sinus. Okay, the posterior ethmoid is here and the frontal sinus is here. So, ready? I remove this part of mucosa. Okay. Right. And I do a biopsy, secondary biopsy of the sphenoid. Okay. Okay. Yes. Irrigation. Cool. Parce qu'on dit ça comme ça. On dit cool. Cool. Okay. 45 fils. Droite fine.
Je le mets dans un pot stéroïde.
Ouais. Oh, the sphenoid mucosa is particular, so it's a reason why I take some piece. Okay. So we have lateral expansion here, but it's now empty. Okay. Okay. You have a lateral expansion here, and the deepness is here. Okay. So cool. Okay. It's correct. So we're going to wash last time, and I think the surgery is finished. And due to the fact that you haven't any bleeding, excessive bleeding, I think it's not necessary to put some hemostatic material. Um, okay. Cool. Finish. Okay, it's clear. So now I wish you a bon appetit. And we, bah, c'est fini. Et we start this afternoon at
Ça, c'était le premier coup
at
pour la
2 o'clock.
Je mets un peu de tout là.
2 o'clock. Because
Là,
after
j'ai du choix. Hein.
Ouais.
La
the
bonne table.
departure for
Je peux en mettre la moitié de ce truc là, peut-être.
degustation.
Mm.
Okay.
Thank you.
Je passe.
Ça va vite, hein.